Welcome to the deep dive. Today we're diving into a really significant topic in vascular surgery, lower extremity amputations. We're drawing heavily from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
That's right. Our mission really is to unpack the key info. How common are these procedures? Why are they done? And importantly, what do the outcomes look like for patients? We want to give you a solid grasp of this complex area.
Okay, and let's start with something that might be a bit surprising. Even with all the amazing advances in saving limbs, major lower extremity amputations, there's still a very real, significant part of vascular practice.
Mm-hmm.
And sometimes, maybe counterintuitively, they aren't seen as a failure of treatment, but actually as a reconstructive choice.
That's such a crucial way to frame it. And it's becoming more relevant, wouldn't you say, with
Right.
people living longer and these epidemics of diabetes and peripheral artery disease, EAD.
Exactly, which affects blood flow. So understanding amputations is, well, critical.
It really is.
So when the decision is made for amputation, what's the main goal? What are surgeons trying to achieve?
The primary goal really is twofold. First, remove all the diseased tissue, could be infection, gangrene, just tissue that's not getting enough blood. Second, leave the patient with the longest possible limb that can actually function well.
Function well and heal properly, I imagine.
Absolutely. Clean healing is paramount. You want to avoid repeat surgeries if at all possible. That's key for recovery, for rehabilitation.
Let's talk numbers for a second. How common are these major amputations in the U.S., like above the ankle?
We're talking about roughly 60,000 major lower extremity amputations each year in the United States. So yeah, it's a significant number.
60,000, wow. And the main drivers, we touched on them, diabetes and PAD.
Definitely the leading risk factors. If you have diabetes, your risk of needing an amputation is about 8 times higher than someone without it.
8 times. That's huge.
Mhm.
And it accounts for a massive chunk of all amputations then.
A huge chunk. Estimates range, but somewhere between, say, 25% and maybe even up to 90% of lower extremity amputations are linked to diabetes.
Wow.
It's because diabetes can cause nerve damage neuropathy, which makes feet vulnerable. Plus, it massively increases the risk of PAZ and infection.
Okay, but here's something interesting from the reading. Despite diabetes being on the rise, the rate of major amputations actually went down for a period, didn't it?
That's right, yeah. Between about 1996 and 2008, there was a noticeable decline. Medicare data suggested something like a 29% drop overall.
Okay.
And specifically for people with diabetes, the age-adjusted rate for non-traumatic major amputations also fell significantly. So better management, newer interventions were likely having an impact then.
That sounds positive. Did that trend continue, though?
Well, it sort of plateaued around 2009, and since then, we've actually seen a slight increase in the overall reported numbers for diabetic Medicare patients.
Oh.
But, and this is important, you have to look at what those numbers include. Often, they now capture foot and toe amputations too, minor ones. Ah, okay, so not just the major limb loss.
Exactly. If you look specifically at below knee and above knee amputation rates, those have pretty much stayed stable or maybe even slightly improved. So the picture for major limb loss hasn't necessarily gotten worse, even if the total amputation number seems higher.
That's a really important distinction. Now, is this pattern the same everywhere, globally?
Oh, not at all. There's a huge variation across the globe, which really tells you that it's not just about the medical condition itself.
Meaning other factors are at play.
For sure, things like access to care, preventative strategies, maybe even cultural differences. You see vastly different rates reported in places like the Navajo Nation compared to, say, Madrid.
What sort of non-medical factors influence these rates?
Well, a couple of things stand out. Physician experience and hospital volume seem to matter. Hospitals doing fewer amputations sometimes have higher rates, paradoxically.
And the supply of vascular specialists makes a difference. More specialists in an area tends to correlate with fewer amputations. But where those specialists decide to practice isn't always driven by medical need. Sometimes it's climate or schools, things like that.
So access to that specialized care isn't evenly distributed.
Not at all. And that affects outcomes. Plus, patient and provider education is key. Earlier identification, quicker referrals, that can definitely prevent some amputations.
What about things like race and insurance? Do they play a role?
Yes, and this is a really difficult area. There are significant disparities. Studies show Black individuals, for instance, are more likely to have an amputation versus a revascularization procedure, even when you control for diabetes.
Why is that?
It's complex, likely involves access to care, how well other health problems are managed, maybe even subtle physician-patient factors. And insurance status absolutely matters. Uninsured patients generally have higher amputation rates. Access is key.
It really highlights the healthcare equity issue, doesn't it?
It really does. And the impact of policies like the Affordable Care Act. Well, the picture is still emerging. Some states saw more amputation admissions, maybe because more people could get care, even if late. Massachusetts, though, saw racial disparities decrease with expanded coverage. It's complicated.
Let's talk about revascularization, those procedures to restore blood flow. How does that relate to amputation rates? It's not just more revascularization equals fewer amputations, is it?
No, it's not that simple. Some studies do show a correlation: higher revascularization rates, lower major amputation rates. But we've also seen a big shift towards endovascular or EV interventions.
Less invasive ones.
Right, often perceived as lower risk. But a failed EV procedure doesn't automatically mean amputation. There might be other options, other attempts.
So other things must be helping keep amputation rates relatively stable, too.
Yeah, definitely. Better awareness of PDA, improved guidelines for managing cholesterol and plaque, better wound care. All these things likely play a part. And interestingly, for high-risk patients, EV might save the limb and maintain walking ability better initially compared to just amputating upfront. But look at a year.
The functional benefit isn't that different.
Doesn't seem to be significantly better after a year, based on some studies.
And that debate about the best approach EV versus open surgery that's still ongoing.
Very much so. Everyone's waiting on the results of the best CLI trial for more guidance there. And one other thing to keep in mind. Revascularization rates might be leveling off, but maybe we're undercounting EV procedures done in outpatient clinics.
Right, the data might not capture everything. Okay, so we got the big picture. Let's narrow down on the specific reasons why amputation becomes the necessary choice. What are the main medical indications?
Okay, so the classic categories are things like acute ischemia, sudden loss of blood flow; chronic ischemia, long-term poor blood flow; severe foot infection; major trauma; or malignancy like cancer. We'll mostly focus on ischemia and infection today as they're most common in vascular disease.
Let's start with acute ischemia. When does that lead to amputation?
Basically, when the tissue damage from lack of blood flow is irreversible, or if there just aren't any good options to restore the blood flow, or if attempts to do so have failed, at that point, removing the dead tissue is crucial.
And chronic ischemia. When does long-term poor blood flow tip over into needing amputation?
That can happen if revascularization attempts have failed, or maybe the patient's vessels just aren't suitable for bypass or stenting, or if the patient has really severe other health problems making major surgery too risky.
Or maybe just very poor function to begin with.
Exactly, poor functional status, or if there's already widespread gangrene or infection that makes saving the foot impossible. Amputation can actually improve quality of life then, relieving pain and preventing sepsis.
You mentioned foot infection, too. That can happen even without major blockages.
Yes, especially in people with diabetic neuropathy. They might not feel an injury, it gets infected, and if the infection becomes severe pedal sepsis even without critical ischemia, amputation might be the only way to control it.
It sounds like these reasons often overlap, though. Ischemia, infection, diabetes.
They absolutely do, which makes it hard sometimes to pinpoint the single indication from records and analyzed outcomes based on that. A patient might have diabetes, PAD, and a bad infection. What's the primary driver? It's often intertwined.
I saw Malone's classifications mentioned. How did those categorize the reasons?
Malone's work gave a useful breakdown. Diabetes complications were number one, like 60–80%. Then infection without diabetes, maybe 15–25%. Ischemia without infection, less common, 5–10%. Then chronic bone infection, trauma, miscellaneous.
But that maybe oversimplifies the diabetes ischemia link.
It does a bit, yeah. As we said, they often go hand in hand. But it highlights that diabetes alone is a massive risk factor, that 8-fold increase we mentioned.
And when a patient comes in, how critical is the state of the limb itself, the tissue damage?
Hugely critical. Even if you successfully restore blood flow, if the tissue damage is too extensive, the limb might still be lost. Sometimes, frankly, the limb is clearly unsalvageable right from the start.
Gangrene, severe sepsis. Those limit options significantly.
Severely. And you always have to factor in the patient's overall health, their comorbidities, and crucially, were they able to walk beforehand? That all plays into the decision.
What percentage of amputations are done as the first treatment versus after trying to save the limb?
For patients with chronic critical limb ischemia, maybe around 25% have a primary amputation. And when amputation happens after trying revascularization, the main reason, maybe 60% of the time, is just that the disease is too widespread non-reconstructible disease.
So sometimes salvage just isn't possible.
Right. One study looked at over 130 amputations, and more than half were either after failed salvage attempts or because revascularization wasn't feasible.
And are there patients who just aren't candidates for aggressive salvage attempts?
Yes. In that same study, about 17% were deemed unsuitable. Maybe too many medical problems already non-ambulatory, or just too high risk for complex surgery. And about a third just presented with limbs that were clearly beyond saving. Primary amputation was the right call there.
We heard about the WIFI classification. How does that help decision-making? WIFI.
Yeah, WII stands for wound, ischemia, and foot infection. It's a scoring system that grades the severity of each of those components.
Okay.
By combining those grades, you get a stage that gives a much better idea of the limb salvage potential and the risk of amputation, especially if revascularization is attempted for chronic limb-threatening ischemia, or CLTI. Higher YOFI stage generally means higher amputation risk after revas.
It's useful for all foot problems.
It's most predictive for CLTI, less so maybe for diabetic foot ulcers if there isn't significant PA involved.
One thing that really stood out was the problem of delays, people waiting too long to see a specialist.
Oh, it's a huge problem. Delay significantly hinders limb salvage. Studies have shown, kind of shockingly, long average delays, weeks, even months, between symptoms like tissue loss or rest pain and actually getting a vascular surgery consult.
Why the delay?
Could be many reasons: patient awareness, referral pathways. One study found only about a quarter of CLTI patients were seen as needing an urgent consult. That delay often means the limb progresses to a point where salvage isn't really on the table anymore, underscores the need for urgency.
Which leads right into that core decision. Try to save the limb with revascularization or go straight to primary amputation. Clearly not always an easy call.
No, definitely not. The goal is always limb salvage if it's feasible and makes sense for the patient. But we're increasingly recognizing that for specific groups, primary amputation might actually be the better path overall.
Nationally, is there a rough balance between the two? Amputation versus revascularization.
The data suggests maybe a ratio around 1 amputation for every 2 revascularization procedures nationally, but that varies a lot by hospital.
Depends on who they see.
Exactly. Referral patterns, surgeon experience, the complexity of cases they handle. A specialized center might try revascularization more often in tough cases.
So who are these patients where primary amputation might be the better initial choice?
It requires a very reasoned individual approach. Someone generally healthy with minimal tissue loss. Aggressive revascularization is usually the way to go. But
Right.
if someone has really poor overall health, multiple serious comorbidities, or very extensive tissue loss, foot destruction, then primary amputation becomes a very serious consideration. Also, poor baseline function, maybe they weren't walking well before, or
Yep.
significant frailty.
It's about the best long-term outcome, not just saving the limb at all costs.
Precisely. What will give the best quality of life and function down the road? Sometimes that's primary amputation.
How has the rise of endovascular, the EV procedures, affected this? Has it meant fewer primary amputations?
It probably has reduced the number of primary major amputations, yes. More patients get a shot at limb salvage, even if they're higher risk for open surgery. But secondary amputations after revasc fails or doesn't lead to healing are definitely not rare.
So fixing the artery doesn't guarantee saving the limb.
Absolutely not. A surprising number of limbs are lost even when the EV procedure itself was technically successful. The vessel is open. Restoring flow is just one piece of the puzzle.
That's crucial. And the functional outcome. Is it always better after revascularization compared to amputation?
Not necessarily. For certain groups, maybe younger patients having a below-knee amputation, their functional outcome might not be that different from someone who had a successful but complex revascularization. We need to see primary amputation as a valid rehabilitative option, not just a failure.
What about those unfit patients too sick for open surgery? Is EV always better for them than primary amputation?
The data there is a bit cautionary. Some studies suggest that while EV might offer better ambulation initially in these frail patients, long-term survival might not be better, maybe even worse in some cases, and the functional benefit might not last.
So for them, primary amputation might be safer and more realistic.
It really might be. especially with extensive foot damage, severe comorbidities, or just anatomy that makes Revast very unlikely to work well long-term. Frailty is a huge factor, and again, delayed referral often tips the balance towards primary amputation being the only viable choice. Specific things, like bad heel gangrene in someone with end-stage kidney disease, often lean towards primary amputation too.
Okay, so the decision to amputate is made. What's the focus then in the period around the surgery?
The perspective has really shifted. It's not just about the surgery itself in the first 30 days anymore. We need to look at the bigger picture, usually the first year or even longer. And the key to success is a team approach. Absolutely crucial.
A multidisciplinary team. Who's typically involved?
It's quite a crew. You've got the patient and family right at the center, then the surgeon, a physiatrist that's a rehab medicine doctor, physical and occupational therapists, the prosthetist who makes the artificial limb.
Nurses, social workers.
Definitely. Nurses are vital. Social workers help with psychosocial issues, maybe a psychologist. Peer support groups can be amazing. And a case manager often helps coordinate everything. The team leader might even shift depending on the phase of recovery.
And you mentioned phases. How do you break down that perioperative period?
We can think of it in roughly 5 stages. 1, preoperative, the decision, the assessments. 2, acute hospital post-op initial recovery, pain control. 3, immediate post-acute wound healing, starting early rehab. 4, intermediate recovery, getting the first prosthesis, dealing with limb volume changes. 5, transition to stable limb is stable, prosthesis gets fine-tuned, working on getting back into life. It's a long process, 12-18 months, easily.
What are the immediate risks with the surgery itself? Mortality, complications?
Overall mortality for major amputations is around 8%. It's higher for above knee, aka, than below knee, BKA. Risk factors include kidney problems, heart issues, pre-op infection, COPD, steroid use, older age.
And complications.
Things like pre-op infection again, alcohol use, steroids, heart and kidney disease, infected wounds increase the risk. The overall complication rate is pretty high, maybe around 34%, with local stump problems in about 10%.
What about common meds like blood thinners or statins? Keep taking them.
Generally, yes. While specific data just for amputation patients is limited, the consensus is usually to continue antiplatelets and statins if they're indicated. And that preoperative cardiac clearance, it's not just about okaying the surgery.
It's about understanding the overall risk.
Exactly. Assessing their cardiac status and risks for the entire perioperative period, not just the OR.
And managing other health issues must be critical.
Absolutely paramount. Optimizing blood pressure, diabetes control, good glucose control is vital for healing kidney function. If they're on dialysis, timing that around surgery is important. Preventing blood clots, VTE prophylaxis is crucial too. Pulmonary emboli are a real danger. And simple things like fall precautions early on.
Infection seems like a major hurdle sometimes. How is that managed?
Aggressively. Surgical removal of all infected tissue is key, plus IV antibiotics. For really severe infections, sometimes a 2-stage approach works better.
2 stages.
Yeah, an initial guillotine amputation to get control of the infection, then a formal, definitive amputation later once things cool down, seems to have fewer complications in those bad cases. For patients who are extremely sick, maybe too unstable for the OR, there's even something called physiologic cryoamputation done at the bedside.
And rehabilitation planning, when does that start?
Ideally before the surgery even happens.
Right.
Centers with dedicated rehab teams just get better outcomes, period. That coordinated approach, addressing medical, functional, social stuff, it can even help reduce major amputations by optimizing other treatments first.
And managing expectations is important throughout.
Crucial. Open communication, reinforcing functional goals, being realistic. That needs to happen consistently all the way through.
Okay, let's talk about one of the most critical surgical decisions.
Yep.
Where to amputate.
Yeah.
The level.
Mhm.
What guides that choice?
3 main goals, really. 1, get rid of all the diseased tissue. 2, ensure the wound can heal properly. 3, create a residual limb, a stump, that's functional, especially for fitting a prosthesis.
And preserving length is generally better.
Generally, yes. More length usually means less energy needed to walk later with a prosthesis. Rehab success is much higher after a below-knee amputation compared to an above-knee.
So BKA patients are more likely to walk again than AKA patients.
Significantly more likely, yes. Prosthetic use is higher after BKA, though actual ambulation rates can sometimes be lower than hoped and might decline over time. Minor amputations toes, part of the foot they preserve, function really well with minimal energy increase. The aim is always the longest healed functional limb.
Why might an amputation fail to heal? Is it just blood flow?
It's often multifactorial. Poor blood flow is a big one, obviously, but infection, hematoma formation, falls causing trauma to the stump. Lots of things can derail healing. That's why no single test perfectly predicts healing.
Tests are better at predicting success than failure.
Generally, yes, and relying too much on one test could lead to amputating higher than necessary, which you really want to avoid.
Because needing a revision, going from a BK to an AK, that's a big setback, right?
Huge setback. Happens in maybe 15–25% of BKAs, carries significant risks itself, mortality, complications, and the psychological impact is massive. Lots of anxiety. Interestingly, anxiety itself seems negatively linked to healing, maybe more so than depression alone. Shows that mind-body connection.
So how do surgeons decide the level? It sounds like a mix of art and science.
It really is. It's about combining objective test results with clinical judgment honed by experience. You start with a thorough physical exam, look for pulses, check skin temperature, assess the extent of gangrene or infection.
And then add in the tests.
Exactly. Use things like ankle and toe pressures, maybe skin perfusion tests, transcutaneous oxygen measurements. Use that data alongside the clinical picture to make the best call.
Let's break down some of those tests. Physical findings first. What do you look for?
Well, the obvious things like gangrene or severe rubor, that deep redness, tell you how far the ischemia extends. That sets the maximum possible length. Feeling a good pulse, just proximal to the planned level. That's a strong predictor of healing.
But not having a pulse doesn't guarantee failure.
Correct. That's where clinical judgment comes in, factoring in the whole picture. Experienced surgeons get good healing rates by integrating all that information. Experience really counts here.
What about skin temperature? Can you reliably measure that?
Subjective feel isn't great, but objective measurements can be pretty accurate, maybe 80–90%. Some studies suggest a threshold around 90 degrees Fahrenheit might indicate good healing potential, but you need to control for room temp compared to the other limb, if possible.
And ankle and toe blood pressures, how useful are they?
Ankle pressures above, say, 60 mmHg suggest decent healing potential for a BKA, but the accuracy varies. Toe pressures seem helpful too, especially for minor foot amputations. One study linked pressures under 38 mmHg to failure in diabetic patients.
What about the ABI, the ankle brachial index?
Lower ABI, like less than 0.5, predicts higher amputation risk in general for high-risk CLTI patients. But a big caveat with pressure measurements, especially in diabetics.
Calcified arteries.
Exactly. Hardened arteries can give falsely high readings, making them less reliable sometimes than just good clinical judgment.
Does an arteriogram, looking at the arteries with dye, help predict healing at a certain level?
Surprisingly, not that well. The correlation is poor. You might even see seemingly open arteries on an angiogram in a limb that ends up not healing. It shows that big vessel flow doesn't always equal good tissue perfusion.
So we need tests that look more directly at tissue blood flow, like isotope scans or skin perfusion pressure.
Precisely. Those are physiologic tests, things like xenon clearance, technetium scintigraphy. They've shown some promise. Skin perfusion pressure, or SPP, is another one. Below a certain pressure, maybe 20 mmHg, failure is likely. Above it, healing is more likely. You can measure SPP with isotopes or using laser Doppler. Skin fluorescence with dye is another option, though inflammation can affect it.
And the one we hear about a lot, TCPO2, transcutaneous oxygen.
Right, TCPO2. Non-invasive, measures oxygen pressure right in the skin. Generally, readings over 40 mmHg are good. Under 20 mmHg is bad for healing. The exact threshold is debated. Some say 30, some say even lower, like 16.
Are there factors that can skew the TCPO2 reading?
Oh, yeah. Infection, inflammation, swelling, edema can all make it falsely low, so sometimes repeat measurements are needed. It's also useful after revascularization to see if it worked. In comparisons, TCPO2 often comes out as more accurate than just pressure.
And it's relatively easy to do.
Yeah, fairly easy to implement in a vascular lab. Many places consider it the preferred objective test, often using that 30 mmHg cutoff, but, and this is key, always use it with the clinical data, not in isolation.
So putting it all together, physical exam, clinical judgment, and then adding objective tests like TCPO2 or SPP or toe pressures seems like the most sensible approach.
That's exactly it. It's the synthesis of all that information. The specific test might vary based on what a center is comfortable with and has available, but TCPO2 is often a good choice. But clinical assessment remains the foundation.
Okay, let's shift gears completely now to what happens after this surgery. Rehabilitation. How critical is that?
Absolutely vital. It's the key to maximizing function and quality of life. We have something like 1.6 million people in the U.S. living with limb loss, mostly due to vascular disease, and that number is projected to more than double by 2050. So effective rehab is incredibly important.
It requires that team approach again.
Definitely. An interdisciplinary team is essential.
What are the big factors affecting rehab potential?
Well, the amputation level is huge, as we discussed. Higher levels mean much higher energy costs for walking. BKA patients just have a far better chance of walking again than AKA patients. So goal one is always the longest possible healed limb.
And the patient's condition before surgery matters too.
Immensely. Their pre-op walking ability, other health problems, comorbidities, age, mental status, all play a big role. Poorer outcomes are often seen in people who weren't walking well before, are older, say over 70, have dementia, end-stage kidney disease, or advanced heart disease.
So you need a personalized plan.
Exactly. A comprehensive plan, updated frequently. That dedicated team makes a huge difference. Optimizing medical issues, managing pain, addressing risk factors that all helps people participate better and function better long-term. And encouraging daily exercise is fundamental.
How is the wound itself managed right after surgery? What kind of dressings are used?
There's actually no universal agreement on the single best way. More options exist for BKAs because you have the knee joint and a longer limb. AKAs often get soft dressings with an elastic wrap.
And for BKAs?
Options include similar soft dressings or rigid plaster casts up to the thigh, sometimes with an immediate prosthesis attached called an IPOP. There are also removable rigid dressings or prefabricated pneumatic ones.
Does the type of dressing affect rehab?
Potentially. Soft dressings might delay rehab a bit. Rigid dressings have shown maybe shorter rehab times. IPOP, the immediate prosthesis, could improve healing in rehab, but requires team familiarity and makes wound checks harder. One study like the prefabricated pneumatic IPOP for fewer complications. IPOP might also reduce the need for surgical revision later.
Then comes picking the actual prosthesis and learning to use it. That sounds critical.
Oh, absolutely crucial. Getting the right durable prosthesis matched to the individual's needs and goals is key. Technology is always advancing lighter materials, more functional designs.
What kinds are there?
Lots of variety for both AKA and BKA. You have high-tech microprocessor knees for AKAs that adapt to how you walk. For BKAs, different ankle types, different socket designs. The key is setting reasonable goals. Not everyone will walk independently outside, but maybe they can use it for transfers, getting around at home.
What determines the ultimate functional outcome? It sounds complex.
It is very complex. Age, pre-op function, comorbidities, mental status, amputation level, healing success, whether it's one leg or both, and the quality of rehab all play a role.
But good outcomes are possible.
Yes, definitely. With good prosthetics and intensive, integrated rehab, some people achieve remarkable independence. Success should really be defined relative to where they were before the amputation.
You mentioned BKA versus AKA outcomes earlier. Can you recap that?
Sure. Maybe 80% of BKA patients with healed limbs can ambulate versus maybe 38–50% of AKA patients. Age over 70 is linked to lower prosthesis use, higher mortality, less independence. Dementia, ESRD, advanced heart disease also negatively impact things. If an AKA patient wasn't walking before surgery, their chances of using a prosthesis are very low and mortality is higher.
I saw some stark mortality figures from the knee day study.
Yeah, they reported about 14% 30-day mortality and 34% at 1 year after major amputation. Higher risk with older age, aka dialysis, heart failure, recent heart attack, immunosuppression, or a guillotine amputation.
What about through knee amputations? Is that too common?
Less common, but can be a good option for some. Potentially better walking speed and lower energy costs than an AKA. Maybe allows earlier weight bearing with lower wound risk than a BKA in elderly or sick patients who might not walk much anyway.
And minor amputations, toes, foot, how do they compare?
Those are really limb salvage procedures. Minimal increase in energy needed for walking. Energy demand basically goes up stepwise from partial foot to AKA.
Age seems like a recurring theme.
It is. Younger patients under 60 with controlled health issues who walked before. They generally do better ambulation, survival, independence. Older patients benefit from rehab but might hit a plateau sooner. And sometimes, if a BKA isn't healing, redoing the BKA slightly higher might be better than converting to an AKA if healing potential is there.
What about the other leg, the contralateral limb? Is it at risk?
Hugely at risk. Within 5 years, maybe 15% to 35% of diabetic patients might need an amputation on the other side. Kidney failure is a bad sign for the remaining limb, too.
So you really need to protect that remaining limb.
Absolutely critical. Ongoing surveillance, patient education, preventative foot care, managing PAD in that limb. It's paramount.
Lastly, let's touch on the psychological side. Amputation must take a huge emotional toll.
It really does. Depression is common, especially in younger amputees. Some research even links depression to a higher risk of amputation. The emotional impact is often compared to losing a spouse.
Does the grief lessen?
The acute bereavement often does, but the sense of loss can linger. It's so important for the team to stress positive outcomes, screen for depression, and get patients psychological support therapy, counseling.
Can depression affect physical recovery?
Yes, it can lead to poor nutrition, less motivation for rehab, potentially delaying healing. Studies show many have depressive symptoms right at the start, though it often improves by about 6 weeks. Early identification and support really improve quality of life.
So mental health care is integral.
It's essential. Psychiatric evaluation, therapy, it's not an add-on, it's part of the core care. Successful rehab itself helps combat depression, addressing social discomfort, body image issues with the prosthesis, building coping skills, all vital. An aggressive supportive rehab program helps minimize that feeling of lost independence. It takes psychologists, nurses, geriatricians, rehab specialists, the whole team.
Okay, so wrapping this up, we've seen that lower extremity amputation, it's complex. It remains a crucial reconstructive tool in certain situations, even if limb salvage is the primary goal. Prevalence, indications, level selection, rehabilitation. So many interacting factors.
That's a great summary. While we always push for limb salvage when it's feasible and right for the patient, sometimes amputation is the best path forward. It demands a really thorough understanding of the patient medically, functionally, and that truly multidisciplinary care, right from the decision through long-term rehab and psychological support.
Right. And thinking ahead, with all the advances we're seeing in both saving limbs and in prosthetic technology, what will the future look like for lower extremity amputation and limb restoration? And maybe more importantly, how can we get even better at tailoring these treatments to not just help people survive, but to truly optimize their quality of life after facing something so challenging? That's definitely something for you to think about. Thanks for joining us on The Deep Dive.